Good morning, everyone. Just here to give you another little update on hyperkalemia treatment because we've had a few clinical incidents lately surrounding some of the medications used in treating hyperkalemia. And so, this is just a talk to just go over and revise what do we actually do and what do we actually use to treat hyperkalemia. Start off with a case study. So this is George. He's a typical Charlie's patient. He's a 72-year-old male. He was found on the floor at home and he comes in combative and confused by the ambulance service. You're able to find out from George's daughter that he's got a history of heart failure, hypertension, he's had a previous acute coronary syndrome, he's got type 2 diabetes and a history of arthritis. George's medications include enalapril, so an ACE inhibitor, spirulactone, so a potassium-sparing diuretic, metoprolol beta blocker, and Celebrex, a COX-2 inhibitor for his arthritis. So you get George into your assessment bay, and the doctor asks you for an ECG and a blood gas. And so this is George's ECG. So you can see here there's a few abnormalities to it. So he's got these tall tenting T waves, and he's also got loss of P waves. So this can be consistent with someone that's got hyperkalemia. Generally in the ranges from about 6 to 7.5. We get George's blood gas back and we can see that his sodium's okay, but his potassium is actually elevated at 7.3. His calcium's a little bit on the low side, his lactate's normal, and his hemoglobin's a bit on the low side as well. And you can see there by George's pH that he's quite severely acidotic at a pH of 6.9. So George is quite unwell. So the first thing that we need to do based on George's presentation is we need to treat his potassium. So yeah, George's potassium 7.3 and he's got those ECG changes occurring. So he's at risk of having arrhythmias from those ECG changes. And certainly if his potassium encroaches any higher, then he will start succumbing to cardiac conduction abnormalities. So when we're treating someone with hyperkalemia, there's 3 steps that we need to take. So we need to correct the cardiac conduction abnormalities. So we've seen the ECG changes. So we need to give George something to stabilize his myocardium. We then need to drive the potassium back into the cell because we know with hyperkalemia it's extracellular rather than intracellular. And we also need to eliminate the potassium from George's body. So they're the 3-step approach to dealing with hyperkalemia. So how do we correct George's conduction abnormalities? So the thing to actually stabilize George's myocardium is we're going to give him calcium. Now calcium won't actually lower his potassium in any way, but it'll actually help to stabilize his myocardium, certainly if he's at risk of having arrhythmias. So this is a temporizing measure, but it can take about 10 to 30 minutes for it to actually be effective. So you need to actually give this some time to work. So what are your indications for giving calcium? So if you've got widening of his QRS, you've got a sine wave pattern on the ECG, and so a sine wave pattern is where your S and your T wave segments merge together, and also in hyperkalemia-induced cardiac arrest. So which calcium can we give? Because we know there's 2 types of calcium. So calcium chloride is 3 times potent of calcium gluconate. So in calcium gluconate, there's 2.2 millimoles of calcium, where in calcium chloride there's 6.8 millimoles of calcium. And so with calcium, it is, if you're having trouble with difficult vascular access and stuff, it's generally preferential to give calcium gluconate, but you might need to give more to get better effect. But if you've got a decent vein or a central line or good central access, then it's safe to give calcium chloride because it is quite potent to the veins and can cause thrombophlebitis. So that's stabilizing George's myocardium. We then need to move on about driving the potassium actually into the cell. And there's 3 approaches here that we can use to actually drive George's potassium into the cell. The main one that we tend to go for is insulin dextrose. So we're using a fast-acting insulin. So Actrapid is the one that is the standard that we use. And so your dose of Actrapid can be between 10 to 20 units, and you also need to give it with dextrose, so 25 to 50 mils of 50 grams of dextrose. And so the insulin drives the potassium from extracellular to intracellular, and we give the glucose to prevent hyperglycemia. Once again, it doesn't work instantaneously, and it can take about 20 to 30 minutes, and it can reduce potassium by about 1 millimole over an hour. The issues and the clinical incidents that we're finding generally treating hyperkalemia are around insulin prescribing. So we want to make sure that the dosing is correct. So it's going to be 10 units. We have had 100 units charted and stuff recently. So make sure it's 10 units. You're going to use a fast-acting insulin. So Actrapid is the standard that we're going to use. You're not going to use any other type of insulin to treat hyperkalemia. In patients that have renal failure, we're also finding having more episodes of hyperglycemia. So we do need to make sure when you're giving someone IV insulin, as well as giving them the glucose, patients with renal failure are at a higher risk of developing hyperglycemia, and all patients that you give IV insulin to are at risk of having hyperglycemia. So you need to keep a close eye on these patient's BSL, certainly for the first hour while the body metabolizes the insulin. So you should be doing a BSL on these patients at least twice within the first hour of having IV dextrose. There is some talk in the literature that when you're treating renal failure patients with hyperkalemia to actually reduce the dose to 5 units, and this will prevent some of that hyperglycemia occurring, but it's also been shown that it's not as effective as reducing the hyperkalemia. So we do have to be mindful of that. Other options we can use to actually drive potassium into the cell is using sodium bicarbonate. So this is sodium bicarb, 8.4%. You can give between 50 to 200 millimoles of this. It is only effective if the patient is acidotic. We know with George it is quite acidotic, so it may be something that's considered. But once again, it doesn't work instantaneously, so you're going to need to give it 30 to 60 minutes for it to have peak effect. Salbutamol, we know that with our asthma patients that when we give them lots of salbutamol, they become hypokalemic. So we know that salbutamol works as well by driving that potassium intracellularly from the extracellular space. And so a salbutamol neb may be charted for these patients as well. So the dose is 10 to 20 milligrams by a nebulizer, and it can lower the potassium by about 1 millimole over 30 minutes, but it is only short-lived and may last only up to 2 hours. So this can be quite effective in renal patients and patients that are fluid overloaded as well. The final thing that we need to do, so we've stabilised the myocardium, we've driven the potassium from extracellular into the intracellular space. We then need to get rid of that excess potassium out of the body, and this is about eliminating potassium from the body. And so there's a few treatments that we can try for this. So there is calcium resonium available. Calcium resonium isn't really effective in the emergency setting. It has limited evidence. It does cause quite severe constipation, and there's a risk of developing clonic necrosis from calcium resonium. So that's the orange stuff that you mix in orange juice. You get them to drink it, and if they can't drink it, you can actually give it to them PR. The specialty teams still seem to be quite for it. The emergency doctors tend to be up to date with the literature and don't prescribe this as much because its effectiveness is quite limited. We can use furosemide, so diuretic, so 20 to 80 milligrams IV. So this is a potassium wasting diuretic, so you're going to cause a diuresis and move some of the potassium that way. Rehydrating the patient, so increasing their renal perfusion, so giving them normal saline CSL to actually move the potassium out through a diuresis. And finally, the gold standard for eliminating potassium from the body is dialysis. So lowers the K by about 1 millimole over the first hour, and then by about another 1 millimole over the next 2 hours. And they need to use a special dialysat fluid for this, so it has very little potassium in it, a lot more bicarbonate. And so these patients and our renal patients that are hyperkalemic will go up to dialysis to have this done. So I think the take-home points that I want you to get from this is that when we look at clinical incidences and stuff around medication management for hyperkalemia, it tends to come down to IV insulin. It works very well for lowering the potassium, okay, but you need to check the dose, okay? So it's either going to be 5 to 10 units of a short-acting actrapid insulin. Okay, you want to be aware in the renal failure patient because these patients have more risk of developing hyperglycemia, and so you want to check the BSL. Remember that giving calcium, if these patients have ECG abnormalities in that, because it will help to stabilize the myocardium while we can drive that potassium intracellularly and then work out a way to eliminate it from the body. And as I said, we need to work out, we do very well at driving the potassium intracellularly, but we also then need to work out ways to eliminate the potassium as well. So if you've got any questions, feel free to ask them in the Teams group. If not, come and see one of the CNS team or staff development team. Thanks everyone. Hope you have a good week.